Welcome back to Anatomiqa. In this session, we will be discussing on the details of the pharyngeal apparatus, which includes pharyngeal arches, pharyngeal clefts, pharyngeal pouches, and pharyngeal membranes. The learning objectives of this session are: describe the development of pharyngeal apparatus, describe the pharyngeal arch arteries and their derivatives, describe the developmental basis of congenital anomalies of pharyngeal apparatus and aortic arch arteries. The development of most of the structures of head and neck region is formed by the mesenchyme, which is derived from paraxial mesoderm, present adjacent to the neural tube dorsally and notochord ventrally, and lateral plate mesoderm, which further is split into splanchnopleuric and somatopleuric intraembryonic mesoderm. The intermediate mesoderm gives rise to genitourinary system. Also, development of head and neck occurs from neural crest cells and thickened regions of ectoderm known as ectodermal plecodes. If you can recall, the neural crest cells are the cells which separate out from the junction of the raised neural tube foldings and the surface ectoderm. The endoderm gives rise to the cranial part of the foregut, developing into pharynx. Now, in this session, we will be discussing only on the development occurring from the mesoderm. In this picture, the ectoderm and endoderm layers are removed to show only the mesoderm, neural tube and neural crest cells. The paraxial mesoderm divides into small cubical masses called somites and somatomeres next to neural tube and the notochord. It gives rise to a large portion of the membranous and cartilaginous components of the neurocranium or the skull cap, all voluntary muscles of the craniofacial region, the dermis and the connective tissues in the dorsal region of the head, and the meninges caudal to the prosencephalon. Intermediate mesoderm forms the genitourinary system, which will be dealt later. Lateral plate mesoderm, which includes two layers, splanchnopleuric and somatopleuric intraembryonic mesoderm, forms the laryngeal cartilages and connective tissue in the neck region. Neural crest cells originate in the neurectoderm of forebrain, midbrain and hindbrain regions and migrate ventrally into the pharyngeal arches and rostrally around the forebrain and optic cup into facial region. In these locations, they form the entire viscerocranium, that is, bones of the face and few parts of the membranous and cartilaginous regions of the neurocranium of skull. They also form all other tissues in these regions, including cartilage, bone, dentin, tendon, dermis, pia and arachnoid matter, sensory neurons and glandular connective tissue. Cells from ectodermal plecodes together with the neural crest forms neurons of the 5th, 7th, 9th and 10th cranial sensory ganglia. In this slide, observe the scanning electron microscopic picture of the paraxial mesoderm dividing into cubical masses forming the somatomeres with incomplete separation and somites completely separated. They are lying on either side of the neural tube and notochord. The most distinctive feature in the development of the head and neck is the presence of pharyngeal apparatus. The old term for these structures is branchial apparatus because they somewhat resemble the gills or branchia of a fish. The pharyngeal apparatus consists of the following: pharyngeal arches, pharyngeal pouches, pharyngeal grooves or clefts, and pharyngeal membranes. All these structures contribute to the development of the face and neck. The pharyngeal arches gives rise to connective tissue, cartilage, muscles, bones and nerves. The pharyngeal pouches gives rise to epithelium and glands. The pharyngeal grooves or cleft give rise to surface epithelium, and pharyngeal membrane contribute to only the tympanic membrane. Pharyngeal apparatus not only contribute to formation of the neck but also play an important role in formation of the face. At the end of the 4th week, the center of the face is formed by the stomodium, which initially appears as slight depression of the surface ectoderm. The stomodium is separated from the cavity of primordial pharynx by a bilaminar membrane called the oropharyngeal membrane, which is formed by the fusion of ectoderm and endoderm. This membrane ruptures approximately by 26 days, and the amniotic cavity communicates with the primordial pharynx and the foregut. By 42 days, 5 mesenchymal prominences can be recognized in the embryo. The ventral portion of the first pharyngeal arch, the mandibular prominences, caudal to the stomodium, which develops into oral cavity, the maxillary prominences, which is the dorsal portion of the first pharyngeal arch, present lateral to the stomodium, and the frontonasal prominence, a slightly rounded elevation cranial to the stomodium. Development of the face is later complemented by the formation of the nasal prominences. The development of face will be dealt in detail in another session. In all cases, differentiation of structures derived from arches, pouches, clefts, and prominences is dependent on epithelial mesenchymal interactions. In this slide, you can observe the scanning electron microscopic picture showing the stomodium developing into oral cavity and its surrounding structures, frontonasal process cranially, maxillary process laterally, and mandibular processes caudally. Let us discuss each part of the pharyngeal apparatus in detail. To start with pharyngeal arches, the pharyngeal arches begins to develop as surface elevations lateral to the developing pharynx in the 4th and 5th weeks and contribute to the characteristic external appearance of the embryo. From the primitive brain, the neural crest cells migrate into the mesenchyme of the pharyngeal arches, contributing to the future head and neck regions. When we take a section across the embryo in the cranial region with pharyngeal arches, how does it look? Let us see how it appears in the section. So this is how the section of the pharyngeal apparatus looks. The dorsal wall of the pharynx is removed and we are viewing the inner surface of the ventral wall of the pharynx. Initially, the pharyngeal apparatus is made of 3 parts: pharyngeal arch, pharyngeal pouch, and pharyngeal cleft. The arch consists of bars of mesenchymal tissue derived from the intraembryonic mesoderm, forming the core of the apparatus, and is covered by the ectoderm on the outside and endoderm on the inner surface. The arches are separated externally by deep clefts, known as the pharyngeal grooves or clefts. Simultaneously, with development of the arches and clefts, a number of outpocketings, the pharyngeal pouches, appear along the lateral walls of the pharynx, which forms the most cranial part of the foregut. The pouches penetrate the surrounding mesenchyme but do not establish an open communication with the external clefts. These 2 layers, that is the ectoderm and endoderm, together form the pharyngeal membranes. Hence, Although development of pharyngeal arches, clefts and pouches resembles formation of gills in fishes and amphibians, in the human embryo, real gills are never formed. Therefore, the term pharyngeal arches, clefts and pouches has been adopted for the human embryo. The typical pharyngeal arch has the following components. Pharyngeal arch artery that arises from the truncus arteriosus of the primordial heart and courses around the primordial pharynx to enter the dorsal aorta. A cartilaginous rod that forms the skeleton and ligaments of the arch. A muscular component that is the primordium of the muscles in the head and neck. The muscles of the arches do not always attach to the bone or cartilage of their own arch, but sometimes migrate into surrounding regions. The origin of these muscles can always be traced by their nerve supply, which is derived from the arch of origin. A nerve that supplies the mucosa and muscles derived from each arch. The arterial arch arteries will be discussed separately later in this session. With this general discussion of the pharyngeal arches, let us now discuss the derivatives of each pharyngeal arch. When we take a section across the embryo in the cranial region with one pharyngeal arch from dorsal to ventral region, let us see how it looks. Ventral and lateral to the pharynx, pharyngeal arch and its components, pharyngeal arch artery, pharyngeal arch cartilage, pharyngeal arch nerve and pharyngeal arch muscle are located. Dorsal to the pharynx, we can observe the notochord, dorsal aorta, and most dorsally is the neural tube. So these are the components of the pharyngeal arch, which is located lateral to the pharynx, and the structures which are located dorsal to the pharynx. To start with the first pharyngeal arch, it is also called as mandibular arch. The first pharyngeal arch consists of a dorsal portion, the maxillary process, which extends forwards beneath the region of the eye, and a ventral portion, the mandibular process, which contains cartilage bar called the Meckel's cartilage. The dorsal end of the cartilage ossify to form two small middle ear bones, the malleus and the incus. The middle part, that is the core of the cartilage, disappears or regresses, but the perichondrium surrounding it forms the anterior ligament of the malleus and sphenomandibular ligament. Mesenchyme of the maxillary process gives rise to the premaxilla, maxilla, zygomatic bone and part of the temporal bone from medial to lateral through membranous ossification. The mesenchymal tissue surrounding the Meckel's cartilage in the mandibular process develops into the mandible by the membranous ossification. Musculature of the first pharyngeal arch includes the muscles of mastication, temporalis, masseter, lateral pterygoid and medial pterygoid, which forms the muscles of mastication. Then anterior belly of digastric, which is inferior to the mandible, mylohyoid, which forms the floor of the mouth, and tensor tympani present in the middle ear, and tensor veli palatini, which is related to the soft palate. The nerve of the first arch is the mandibular branch of the trigeminal nerve. So, the muscles derived from the first arch will be supplied by the mandibular branch of the trigeminal nerve. Since mesenchyme from the first arch also contributes to the development of the dermis of the skin of the face, sensory supply to the skin of the face is provided by ophthalmic, maxillary and mandibular branches of the trigeminal nerve. We have completed the development of all the components of the first arch derivatives. Now coming to the second pharyngeal arch, it is also called as the hyoid arch. The cartilage of the second or hyoid arch is called Richard's cartilage. The dorsal end of the cartilage ossifies and gives rise to stapes of the middle ear and styloid process of the temporal bone. The ventral part of the cartilage ossifies to develop into the lesser cornu or the lesser horn and upper part of the body of the hyoid bone. The part of the cartilage between the styloid process and the hyoid bone regresses and its perichondrium forms the stylohyoid ligament. Muscles derived from the second pharyngeal arch or hyoid arch are the stapedius present in the middle ear cavity, stylohyoid, posterior belly of the digastric. Both muscles are present in the neck, auricular muscles surrounding the external ear, muscles of the facial expression. The nerve of the second pharyngeal arch is the facial nerve which supplies all these muscles. In the third pharyngeal arch, the cartilage component of the third pharyngeal arch produces the lower part of the body of hyoid bone and greater cornu of the hyoid bone. The muscular component gives rise to the one pair of muscles, the stylopharyngeus muscles. These muscles are innervated by the glossopharyngeal nerve, which is the nerve of the third arch. In the fourth and sixth pharyngeal arches, the cartilaginous components of both arches fuse to form all cartilages of the larynx except epiglottis. The cartilages of the larynx are three unpaired cartilages: the thyroid cartilage, the cricoid cartilage, and three paired cartilages, the arytenoid, corniculate, and cuneiform cartilages, which cannot be seen in the lateral view. They are present on the posterior wall of the larynx. The epiglottis, which is the third unpaired cartilage, develops from the neural crest cells. The laryngeal cartilages seen from anterior and posterior aspects of the larynx in the adult. From anterior aspect, the three unpaired cartilages, cricoid cartilage, thyroid cartilage, and the epiglottis can be seen. From the posterior aspect, along with cricoid, thyroid, and epiglottis, we can observe the three paired cartilages also: arytenoid cartilages, corniculate, and cuneiform cartilages. The muscles which are derived from the fourth arch are the cricoid and thyroid muscle, which is called as the cricothyroid, which is the muscle of the larynx, levator palatini, which is the muscle of the soft palate, and constrictors of the pharynx. These muscles are innervated by the nerve derived from the fourth arch, that is the superior laryngeal nerve, which is the branch of the vagus. All the intrinsic muscles of the larynx except cricothyroid are derived from the sixth pharyngeal arch. These muscles are supplied by the recurrent laryngeal nerve, which is the branch of the vagus, derived from the sixth pharyngeal arch. We are in the last component of the pharyngeal arch, that is the aortic arch arteries. Hope you remember this diagram of the primitive heart tube. To know more about its development, please watch the video on development of heart. The aortic arch arteries arise from the aortic sac, the most distal part, and is cranial to the truncus arteriosus. The pharyngeal or the aortic arch arteries pass through the mesenchyme of the pharyngeal arches from the aortic sac and terminate in the right and left dorsal aortae. In the region of the pharyngeal arches, the dorsal aortae remains as unpaired structures, but beyond the pharyngeal arches, the two dorsal aortae fuse to form a single dorsal aorta. Let us enlarge the region of the pharyngeal arches and look at its development. The pharyngeal arches and their vessels appear in a craniocaudal sequence and they do not develop simultaneously. The aortic sac contributes a branch to each new pharyngeal arch as it forms, giving rise to a total of 5 pairs of the arteries. The fifth arch either never forms or forms incompletely and then regresses. Consequently, the 5 arches are numbered from cranial to caudal end as 1 to 6. Now let us take only the pharyngeal arch arteries and see its further development. The right and left dorsal aorta join with each other to form single dorsal aorta beyond the pharyngeal arches. The pharyngeal arch arteries arise from the aortic sac and join the right and left dorsal aorta respectively. The aortic arch arteries develop from cranial to caudal end and are numbered from 1 to 6 from cranial to caudal end. The fifth aortic arch artery might not develop, or even if it develops, it regresses very early. During further development, the arterial pattern becomes modified and some vessels regress completely. Division of the truncus arteriosus by the aorticopulmonary septum divides the outflow channel of the art into the ventral aorta and the pulmonary trunk. The aortic sac then forms right horn of the aortic sac and the left horn of the aortic sac, which subsequently gives rise to the brachiocephalic artery on the right side and the proximal segment of the aorta, that is ascending aorta, on the left side. By day 27, most of the first aortic arch has disappeared, although a small portion persists to form the maxillary artery. Similarly, the second aortic arch soon disappears. The remaining portions of this arch develop into hyoid and stapedial arteries. In the day 29 embryo, the first and second aortic arches have disappeared. The third, fourth, and sixth arches are large. The conotruncal region has divided so that the fourth arches are continuous with the aortic sac or the ventral aorta, and the sixth arches are now continuous with the pulmonary trunk. With further development, the aortic arch system loses its original symmetrical form and establishes the definitive pattern. The following changes occur. The third aortic arch forms the common carotid artery and the first part of the internal carotid artery. The remainder of the internal carotid artery is formed by the dorsal aorta cranial to the third aortic arch. The external carotid artery sprouts from the third aortic arch. The fourth aortic arch persists on both sides, but its ultimate fate is different on the right and left sides. On the left, it forms part of the arch of aorta beyond the left common carotid artery, and the rest of the arch is formed by the left dorsal aorta up to the left subclavian artery. On the right, the fourth arch forms the proximal segment of the right subclavian artery, the distal part of which is formed by the portion of the right dorsal aorta and the seventh intersegmental artery. The fifth aortic arch never forms or forms incompletely and then regresses. The sixth aortic arch, also known as the pulmonary arch, gives off an important branch, pulmonary arteries, that grows towards the developing lung bud. On the right side, the proximal part becomes the proximal segment of the right pulmonary artery. The distal portion of the arch loses its connection with the dorsal aorta and disappears. On the left, the proximal segment develops into the left pulmonary artery and the distal part persists during intrauterine life as the ductus arteriosus, which in the adult remains as the ligamentum arteriosum. A number of other changes occur along with alterations in the aortic arch system. The dorsal aorta between the third and fourth arches, known as the carotid duct, is obliterated. The right dorsal aorta between the origin of the right 7th intersegmental artery and the junction with the left dorsal aorta disappears. Initially, the right recurrent and the left recurrent laryngeal nerves, branches of the vagus, supply the 6th pharyngeal arches. When the heart descends, they hook around the 6th aortic arches and ascend again to the larynx, which accounts for the recurrent course. On the right, when the distal part of the 6th aortic arch and the 5th aortic arch disappear, the recurrent laryngeal nerve moves up and hooks around the right subclavian artery. On the left, the nerve does not move up since the distal part of the 6th aortic arch persists as the ductus arteriosus, which later forms the ligamentum arteriosum. Now, we will discuss the second component of the pharyngeal apparatus, that is the pharyngeal pouches. When we see the primordial pharynx, it widens cranially where it joins the stromodium and narrows caudally where it joins the esophagus. The endoderm of the pharynx lines the internal surfaces of the pharyngeal arches and passes into the pharyngeal pouches. These pairs of pouches develop in a craniocaudal sequence between the arches. The human embryo has 5 pairs of pharyngeal pouches. 4 pairs of the pouches are well defined and the 5th pair is either rudimentary or absent. The first pair of the pouch lies between the first and second pharyngeal arches. The second pair lies between second and third arches, and so on. The endoderm of the pouches contacts the ectoderm of the pharyngeal clefts or grooves, which together forms the double-layered membranes called pharyngeal membranes. Since the epithelial endodermal lining of the pouches gives rise to a number of important organs, the fate of each pouch is discussed separately. The first pharyngeal pouch forms a stalk-like diverticulum, the tubotympanic recess, which comes in contact with the epithelial lining of the first pharyngeal cleft, which in future develops into external auditory meatus or the external acoustic meatus. The distal portion of the diverticulum widens into a sac-like structure and develops into primitive tympanic cavity or midlear cavity. And the proximal part remains narrow, forming the auditory tube or the eustachian tube or pharyngotympanic tube. This pharyngotympanic tube connects the tympanic cavity and the pharynx. The lining of the tympanic cavity later helps in the formation of the tympanic membrane or the eardrum. The second pharyngeal pouch. The epithelial lining of the second pharyngeal pouch, that is the endoderm, proliferates and forms buds. These buds penetrate into the surrounding mesenchyme. The buds are secondarily invaded by the mesodermal tissue, forming the primordium of the palatine tonsils, which gradually develops into the palatine tonsils. The central part of the bud breaks down and forms the tonsillar crypts, which are lined by endoderm. During the 3rd and 5th months, the mesenchyme around the crypts differentiates into lymphatic tissue, which soon arranges itself into the lymphatic nodules of the palatine tonsil. Part of the pouch remains and is found in the adult as the tonsillar fossa. Coming to the 3rd pharyngeal pouch. The 3rd pouches are characterized at their distal extremity by a dorsal and a ventral part. The dorsal part is solid and bulbar in shape, and the ventral part is hollow and elongated. In the 5th week, epithelium of the dorsal region of the 3rd pouch differentiates into inferior parathyroid gland, while the epithelium of the ventral region proliferates to form the thymus and the pouch is obliterated. Both the gland primordium loses their connection with the pharyngeal wall and move in a caudal and medial direction. The main portion of the thymus moves rapidly to its final position in the anterior part of the superior mediastinum of the thorax, where it fuses with its counterpart from the opposite side. The tail portion of the thymus sometimes persists either embedded in the thyroid gland or as isolated thymic nests. Growth and development of the thymus continue until puberty. In the young child, the thymus occupies considerable space in the thorax and lies behind the sternum and anterior to the pericardium and great vessels. In older persons, it is difficult to recognize since it is atrophied and replaced by the fatty tissue. The inferior parathyroid gland moves medially and rests on the dorsal surface of the thyroid gland. Coming to the 4th pharyngeal pouch, epithelium of the dorsal region of the 4th pharyngeal pouch develops into the superior parathyroid gland. The parathyroid gland loses contact with the ventral wall of the pharynx and gets attached itself to the dorsal surface of the thyroid gland. The elongated ventral region of the 4th pouch gives rise to the ultimobronchial body or the ultimopharyngeal body, which is later incorporated into the thyroid gland. Cells of the ultimobronchial body derived from the neural crest cells give rise to the parafollicular or C cells of the thyroid gland. These cells secrete calcitonin, a hormone involved in regulation of the calcium level in the blood. Now we are in the 3rd component of the pharyngeal apparatus, which is the pharyngeal clefts. The 5-week embryo is characterized by the presence of 4 pharyngeal grooves or clefts, of which only one contributes to the definitive structure of the embryo. The dorsal part of the first cleft penetrates the underlying mesenchyme and gives rise to the external auditory meatus or the external acoustic meatus. The epithelial lining at the bottom of the meatus participates in the formation of the eardrum. The mesenchyme of the second arch proliferates and overgrows the 3rd and 4th arches, overlapping them, and merges with the epicardial ridge in the lower part of the neck. The 2nd, 3rd and 4th clefts in the beginning are open to outside but later, as the development proceeds, they lose contact with the outside and they form a cavity lined with the ectodermal epithelium, which is called the cervical sinus. The cervical sinus is usually obliterated with the development of neck. Now coming to the last component of the pharyngeal apparatus, that is the pharyngeal membrane. These membranes form where the epithelium of a groove, that is the ectoderm, come in contact with the epithelium of a pouch, that is the endoderm. The pharyngeal membranes are formed in the floors of the pharyngeal grooves during the 4th week. Only the first pair contributes to the formation of adult structures called the tympanic membrane present between the external auditory meatus and the middle ear cavity. In the middle, the tympanic membrane is formed by the mesenchymal tissue. Hence, the tympanic membrane is formed by 3 tissues from medial to lateral. It is the endoderm, mesoderm and the ectoderm. The table shows the derivatives of each component of pharyngeal arches, that is the nerve, muscle and skeleton of the specific arch. So make a tabular column of the different components of the pharyngeal arches, which will be helpful in the last minute revision. This table shows the derivatives of the specific pharyngeal pouches. Now after the normal development of the pharyngeal apparatus, now we are entering the birth defects involving the pharyngeal region. That is, we are talking about the clinical anatomy. Ectopic thymus and the parathyroid tissue. The glandular tissue derived from the pouches undergoes migration to reach their adult positions in the normal development. But during the migration, some remnants of the tissue may persist on the pathway and form the accessory glands. The parathyroids are highly variable in number and location. They may be found anywhere near or within the thyroid gland or thymus. The superior glands are more constant in position than the inferior ones. Occasionally, an inferior parathyroid gland does not descend and remains near the bifurcation of the common carotid artery. In other cases, it may accompany the thymus into the thorax. The thymus might remain in the neck without descending into the superior mediastinum. Cervical vestiges. We have seen normally the pharyngeal cartilages disappear except for the parts that form the ligaments or bones. But in unusual cases, they do not disappear and the cartilaginous or bony remnants of the pharyngeal arch cartilages appear under the skin on the side of the neck. These are usually found anterior to the inferior third of the sternocleidomastoid muscle. Neural crest cells and the craniofacial defects. Neural crest cells are essential for the formation of much of the craniofacial region. Consequently, any disruption to the development of the neural crest cells results in the craniofacial malformations. We know that neural crest cells also contribute significantly in the development of heart, like the conotruncal endocardial cushions, which separates the outflow tract of the heart into pulmonary and aortic channels, and the regulation of the secondary heart field. Because of this, many infants with craniofacial defects are mostly associated with cardiac abnormalities, including the persistent truncus arteriosus, tetralogy of Fallot, and the transposition of the great vessels. Neural crest cells are particularly vulnerable cell population. and are easily killed by compounds such as alcohol and retinoic acid. First arch syndrome results from abnormal development of first pharyngeal arch. It is caused by a lack of migration of neural crest cells into the first pharyngeal arch. Two main manifestations of first arch syndromes are Tracher-Collins syndrome and Pierre-Robin syndrome. Tracher-Collins syndrome is also called as mandibulofacial dysostosis. It is characterized by malar hypoplasia due to underdevelopment of the zygomatic bones, mandibular hypoplasia, down-slanting palpebral fissures, and malformed external ears. Tracher-Collins syndrome is inherited as an autosomal dominant disorder caused by mutation in the TCOF1 gene on chromosome 5q for the protein called treacle. In 60% of cases, the mutation arises as new mutations. Pierre-Robin syndrome. It is also called as Robin sequence and may occur independently or in association with other syndromes and malformations. Robin sequence occurs in approximately 1 in 8,500 births. Like Tracher-Collins syndrome, Robin sequence has defective features of first arch structures with development of the mandible most severely affected. Infants usually have a triad of clinical features: micrognathia, which is underdevelopment of mandible; glossoptosis, which is the posteriorly placed tongue due to which there may be airway obstruction. The third feature is the cleft palate. In this diagrammatic representation, you can observe the cleft in the hard palate forming the roof of the oral cavity. The cleft can be limited only to the palate, which is called cleft palate, or it can be associated with the lip called the cleft lip and palate. Cleft lip and palate can be unilateral or bilateral. DiGeorge syndrome, or it is also called as Cash-22 syndrome or 22q11 deletion syndrome. It is caused by a microdeletion of a region in the chromosome 22q112. That region is also called the DiGeorge chromosomal region. This results in the failure of pharyngeal pouches 3 and 4 to differentiate into the thymus and parathyroid glands. Absence of thymus leads to immunodeficiency and absence of parathyroid leads to hypocalcemia. Due to defective neural crest cell migration, DiGeorge syndrome is usually accompanied by facial anomalies resembling first arch syndrome, that is micrognathia, low set ears, cleft lip and palate, and cardiovascular anomalies leading to cyanosis. There may be tongue tie, also called as ankyloglossia, which occurs when the frenulum of the tongue extends to the tip of the tongue, which prevents the protrusion of the tongue. Auriculovertebral spectrum, also called as Goldenhar syndrome, includes a number of craniofacial abnormalities that usually involve the maxillary, temporal, and zygomatic bones, which are small and flat, leading to hemifacial microsomia. Causes of hemifacial microsomia are unknown. Asymmetry is present in 65% of the cases, which occur in 1 in 5,600 births. The commonly observed features in these patients are ear anomalies, which include microtia or anotia. Eye anomalies may be tumors and dermoids in the eyeball, and Vertebral anomalies including fused and hemivertebrae and spina bifida defects where the posterior arch is defective in the vertebra. Other malformations which occur in 50% of cases include cardiac abnormalities such as tetralogy of Fallot and ventricular septal defects. Coming to the branchial fistulas or the pharyngeal fistulas, it occurs when pharyngeal pouch 2 and pharyngeal groove 2 persist, thereby forming a patent opening from the internal tonsillar area to the external neck. The fistula begins inside the throat near the tonsils, travel through the neck and open to the outside near the anterior border of the sternocleidomastoid. Branchial cyst or pharyngeal cyst, or also called as cervical cyst, occurs when parts of the pharyngeal grooves 2, 3 and 4 that are normally obliterated persist, thereby forming a cyst. In the normal development, the pharyngeal grooves 2, 3 and 4 is overlapped by the overgrowing of the mesenchyme from the pharyngeal arch 2 and forms the cervical sinus. As the development proceeds, the cervical sinus present in the neck region gradually obliterates. If the cervical sinus persists, it leads to fluid-filled pharyngeal cyst. It is generally found near the angle of the mandible. Cervical cysts often do not become apparent until late childhood or early adulthood, when they produce a slowly enlarging, painless swelling in the neck. The cysts enlarge because of the accumulation of fluid and cellular debris derived from the desquamation of their epithelial lining. Coming to the abnormalities of the pharyngeal arch arteries, patent ductus arteriosus. Under normal conditions, the ductus arteriosus is functionally closed through contraction of its muscular wall shortly after birth and forms the ligamentum arteriosum. Anatomical closure by means of proliferation of the intima takes 1 to 3 months. In some cases, the closure might not occur and the ductus arteriosus persists. It is called as the patent ductus arteriosus. This is one of the most frequently occurring abnormalities of the great vessels, which is almost 8 in 10,000 births. It can be an isolated abnormality or may accompany other art defects. The defects that cause large differences between the aortic and pulmonary pressures may cause increased blood flow through the ductus, preventing its normal closure. Coarctation of the aorta. It occurs in 3.2 in 10,000 births. In this condition, the aortic lumen below the origin of the left subclavian artery is significantly narrowed. The constriction may be above or below the entrance of the ductus arteriosus. If the constriction is above the ductus arteriosus, it is called preductal coarctation of aorta. In this type, the ductus arteriosus is persistent and the blood flows through the ductus arteriosus and is distributed to the parts of the body. If the constriction is below the ductus arteriosus, it is called the postductal coarctation of aorta. In this type, which is more common, the ductus arteriosus is usually obliterated and the collateral circulation is established between the proximal and distal parts of the aorta through the subclavian artery and its branches. In this manner, the lower part of the body is supplied with blood. Classic clinical signs associated with this condition include hypertension in the right arm concomitant with lower blood pressure in the legs. The cause of aortic narrowing is primarily an abnormality in the tunica media of the aorta, followed by the proliferations in the tunica intima. Abnormal right subclavian artery. First, let us look into the normal development. The distal part of the right dorsal aorta between the 7th intersegmental artery and the junction of the left dorsal aorta obliterates. The proximal part of the right dorsal aorta along with the right 7th intersegmental artery and 4th right aortic arch forms the right subclavian artery. This is the normal development of the right subclavian artery. In the abnormal development of abnormal origin of right subclavian artery, the right 4th aortic arch and the proximal part of the right dorsal aorta are obliterated. The abnormal origin of the right subclavian artery is formed by the abnormal persistent distal portion of the right dorsal aorta and the right 7th intersegmental artery. With shortening of the aorta, the origin of the abnormal right subclavian artery moves just below that of the left subclavian artery. Since the stem is derived from the right dorsal aorta, the abnormal artery must cross the midline behind the esophagus and the trachea to reach the right side. This location does not usually cause problems with swallowing or breathing, since neither the esophagus nor the trachea is severely compressed. Double aortic arch. To repeat the normal development on the right side as in the previous case, the distal part of the dorsal aorta between the 7th intersegmental artery and the junction of the left dorsal aorta obliterates, and the proximal part of the dorsal aorta along with the right 7th intersegmental artery and the right 4th aortic arch forms the right subclavian artery. In the case of the abnormal development, the distal part of the dorsal aorta persists between the origin of the right 7th intersegmental artery and its junction with the left dorsal aorta, giving rise to the right aortic arch. The left aortic arch passes anterior to and the right aortic arch passes posterior to the esophagus and the trachea. So, a vascular ring is formed and surrounds the trachea and esophagus and commonly compresses these structures, causing difficulties in breathing and swallowing. In a right aortic arch, the distal part of the left dorsal aorta is obliterated and the entire dorsal aorta on the right side persists, forming the right aortic arch. An interrupted aortic arch is caused by the obliteration of the 4th aortic arch on the left side. Right side, the 4th aortic arch normally obliterates. It is frequently combined with an abnormal origin of the right subclavian artery. The ductus arteriosus remains open. Since there is obliteration of the left 4th aortic arch, there is no formation of the usual arch of aorta, and the blood supply takes alternate routes. The aortic trunk supplies the head through the two common carotid arteries. The pulmonary trunk through the ductus arteriosus supplies the rest of the body. This blood passing through the descending aorta and subclavian arteries are supplied with low oxygen content. With this, we end the session on the pharyngeal apparatus and its clinical anatomy. Thank you for watching till the end. If you like the video, like, share and subscribe to the channel.